we should definitely start. So can I officially give the introduction? Professor Baum?
Yes.
Professor Chaudhary, with your permission?
Of course, yeah.
Yes. So you have to put the screen on me. Huh? Right. Right. So good afternoon, ladies and gentlemen. It's a very nice, pleasant afternoon here in Chennai, which is slightly overcast and highly unusual for Chennai, but very, very pleasant. And thank you for joining us today. We have 100 participants who have already logged in and from different countries, as we were discussing. And what is of interest today is that we are going to be talking about one of the most trending and upcoming modalities in the imaging and treatment of prostate cancer. And that is to do with something called Theranostics. And as a brief, Theranostics is a portmanteau, or it's a combination of two different words, which is the Thera stands for therapeutic and the Gnostic stands for diagnostic. And the idea is to use a common molecule, both as a diagnostic as a therapeutic vector for treatment of disease. And one of the things that has really catapulted Theranostics to the current position of power that it enjoys is PSMA, and that is prostate-specific membrane antigen. So today we are going to explore the evolution, the basis, the science, the impact, the evidence, and the relevance of this molecule called PSMA. And PSMA-based scanning and targeted internal radiation therapy, both with alpha and beta emitters, have made massive inroads both into the diagnostic as well as the therapeutic space, as well as armamentarium across the world. And especially so in India, for the past 5 or 6 years, we have been fortunate enough to have both PSMA-based scans as well as therapy. And the only thing that I still feel is the dissemination of knowledge as well as the awareness around PSMA as the potential that it has to replace conventional imaging, as well as many of the conventional treatment modalities, is still lacking for our urology as well as oncology, and sometimes even the nuclear medicine community. And it is precisely to address this particular lacunae that we are hosting our very first webinar on Theranostics from the Apollo group, as well as from Apollo Proton Cancer Center, as the first educational webinar from our side. So the schedule for today is that we have 3 speakers who are actual heavyweights in the PSMA-based diagnostic as well as therapeutic space, giving lectures for each of 20 to 25 minutes. And after that, we have them join us along with other urologists and oncologists on a panel, which will be moderated by a clinical oncologist, Professor Raja, who's going to join us later. And we expect this webinar to be on for the next 2 hours, and all the speakers to stick to their time, as well as any of the participants who are not actually speaking to switch off their mobile phones. And once again, thank you so much for joining us. And now, without much ado, I would like to introduce you to our first speaker, that is Dr. Simon Chowdhary. And Dr. Simon is the consultant oncologist with a special interest in urology and uro-oncology, and he's based out of London. And his topic is going to be an introduction to PSMA in clinical oncology. May I also request anyone who's not a speaker to please switch off their mobile phone and make sure that they're on mute. Your videos can, of course, be on, but please make sure that you're muted so that you do not disturb the speaker. Thank you so much, and all the best. Dr. Simon, over to you.
Thank you, Ajit, and thanks everyone for logging in at this strange time. I feel a slight fraud because PSMA is something I'm new to. I'm here to learn. I see my role as very much talking about advances in metastatic prostate cancer and potentially the role of novel imaging, particularly PSMA, and as Ajit very eloquently puts, the role of it as both a diagnostic and a therapy, a theranostic. And I think Richard and the other speakers are going to elucidate that further. So this is for my disclosures. And again, I wonder if people could put things on mute, just because lots of us online. So these are my disclosures, and I think are relevant to this. As I said, I'm not an expert in this field, but I'm here to just give you my sense of things. So it's not an introduction to PSMA. I think the other speakers are real giants in the field, but sort of when PSMA may fit with current treatment, and using prostate cancer and metastatic prostate cancer as a model for this. So where we are with prostate cancer and where we're going. I'm a very big cricket fan, so I see Ajit here as I'd like to thank him for organising things. He's adopted an MS Dhoni-like role, rallying everyone here, and I think Chennai have still got a little way to go in the IPL, but it's early days, so we shall see. So this is it's a time for us all to reflect, time to reset. This very strange time where we're all thinking about different things. This is near where my mum lives, and I can't go and visit her in the north of England because we're locked down in the UK. But I suppose it gives us opportunities like this to connect in different ways. And it's lovely to connect with India, where my father was from, and I'll be very keen to connect in the future. And as I say, Ajit and the Apollo group, I'm very grateful for herding us all together today. So what am I going to talk about? I'm going to talk a little about androgen receptor targeting, and then where we are in metastatic disease and where we're going, and sort of how we adopt new therapies and how we get that, as Ajit sort of touched upon, how we get that balance right between innovation, but also getting the evidence to really drive what we're doing going forward. So what's the future? What's the present? And there's a lot of talk about personalized therapy and this move towards novel imaging to direct therapy, theranostics. How do we incorporate genomics where that's concerned? And what's important to patients and what's important to doctors? And those two are not always necessarily the same. And there's perhaps a middle ground there that needs to be reclaimed by us all going forward. So when people talk about personalized therapy and they sort of say, well, in prostate cancer, everyone gets the same treatment and it's all the same. Well, what I would say is one of the first personalized treatments was actually Huggins and Hodges back in the 1940s, for which they won their Nobel Prize. And they basically demonstrated that androgen receptor biology was critical to the progression, survival, and dissemination of prostate cancer. And what they discovered was that androgen receptor biology was very critical. We can see here on the left a bone scan, and we'll talk about how novel imaging has sort of provided greater sensitivity and specificity than that. But what I'd say is that we mustn't forget the old and look at how that partners with the new. So thinking about how we go forward, and I was going to talk about metastatic disease at presentation, so what we call hormone sensitive or castrate sensitive disease. We know that androgen deprivation therapy alone works and works in the majority of patients, but it works for a finite period of time. And I suppose one of the things is, how does that fit in with where we're going forwards? So when we think about patients, there are various presentations in this situation, and that's basically patients who present with new disease or recurrent disease after radical treatment. Age is clearly important, and burden of disease is very important for minimal to widespread disease. And I think this is important more prognostically than predictively, at least with conventional imaging. And by conventional imaging, I mean CT and bone scan. So I suppose what we're thinking about is, as we move to novel imaging, and we'll talk about PSMA and other people will talk about PSMA PET scanning, does that affect our definitions and how we look at things? So we've seen that in recent years that the addition of new therapies to androgen deprivation therapies have shown great benefits. But how do we decide on treatment going forward, and what does that mean? And how do we define prognostically? You may well have seen these models on the left-hand side of my screen is the model from Chris Tweedy in the Charted study, which looked at 4 or more bone metastases on conventional imaging, as I say, CT and bone scan, with one outside the pelvis showing high volume or higher risk, poor prognostic disease. On the right, lower volume disease, defined as 3 or more bone metastases, visceral metastases, or patients with a Gleason score of 8 or above. Most of the patients that we see in our practice in the UK have this high volume disease. So we need to just be careful about that. This is a busy slide, but it just looks at studies in this newly diagnosed space, going from docetaxel through to the androgen receptor targeted therapies. And we can see that actually the hazard ratios or the benefit is greater as we go down into apalutamide, abiraterone, enzalutamide. And I think those drugs, in my opinion, are better than docetaxel, the chemotherapy in this situation. You may be familiar with how these drugs work, but I'm conscious it's a mixed audience. So these drugs also modulate the androgen receptor, and this is just a cartoon looking at the androgen receptor and the binding of testosterone. What we know from this is that testosterone binds the androgen receptor, it dimerizes, and then gets translocated in the nucleus of the cell, providing a signal for growth, proliferation, and survival. We know that by decreasing testosterone, either by its biosynthesis or blocking its interaction with the receptor is very potent. And that has shown benefit in addition to androgen deprivation or castration. And I believe that's the way we're going with regards to things. So this is a study, the Latitude Study, and this study looked at androgen deprivation therapy versus androgen deprivation therapy plus abiraterone, a drug that lowers testosterone further. I'm just going to give you this study just looking at two things really: the benefit of these drugs, but also the limitations and why we need novel therapies going forward. You can see a large study, 1,200 patients, and all of them high-risk, newly diagnosed patients. We can see that, I don't know where this red line's come from, but anyway, I apologize for that. Clearly my IT skills are worse than I think. But we can see here that if we look at radiographic, this conventional radiographic progression, for patients having androgen deprivation therapy alone, it's just over 12 months. So we mustn't underestimate the benefit there. If we look at overall survival, again, we can see here that for androgen deprivation therapy alone, it's only of the order of 3 years. With abiraterone, it's improved significantly to 54 months, an improvement of 18 months. But still, we're in the situation where we need treatments for many men beyond this dual or hard androgen blockade. If we look at new therapies for prostate cancer, and these are FDA-approved therapies, we can see that the treatment landscape has several new therapies here, but I would caution you here and say how many of these therapies have been shown to have evidence post-abiraterone or enzalutamide, the common drugs in this situation. And basically, the number of therapies in this situation is actually relatively low. Cabazitaxel has shown a benefit in rapid progressors on abiraterone or enzalutamide, and olaparib, which we may talk about in the discussion, which is a PARP inhibitor, has shown in a genomically defined group of patients with DNA damage repair deficiency or homologous recombination deficiency, a benefit in this situation. And that's where olaparib sits in either the pre or post-docetaxel setting. So next generation sequencing that people talk about, I would say, what is the role of genomics in prostate cancer? I think it's there, but it's probably a relatively small number of patients that have actionable mutations. Is this ready for the clinic? Yes, but we need to look at its limitations. If we think about prostate-specific membrane antigen, I'm not going to go into great detail here because I think the other speakers are. This is both a target for imaging for both imaging and therapy, and we'll talk about this. The Theranostics that Ajit eloquently spoke about. PSMA is this type 2 glycoprotein that sits across the membrane. It has an intracellular component, a transmembrane component, a large extracellular domain that can be targeted. It's highly expressed in prostate cancer, and its expression increases with aggressiveness, metastatic disease, and recurrence. So it's a very valid target going forward. It's also expressed in some healthy tissues, and that may lead to side effects of some of the theranostics, but it's an excellent target for both imaging and therapy of prostate cancer. So if we're looking at novel imaging, and we think about PSMA PET here, how does that change what we're doing? Well, in some ways, we get more information. So there's a new landscape with subpopulations. Patients who are negative on conventional imaging are suddenly positive with novel imaging. And what does that mean, and how may that impact management and treatment for patients? It may affect risk stratification. I think one of the bits, and this is a very important slide presented by Dr. Vapiwala at this year's GeoASCO Symposia. And I think the key bit here is that you can get a lead time bias. And also you look, you find, you act. And what he touched upon here was you have a natural history of prostate cancer or any disease, and you go from localized disease that relapse to symptomatic metastases to death. If you've got new imaging and intervention, you may well find disease and you may intervene. And therefore you find disease and you believe that this period here, you're benefiting the patient, but you may not be. You may then just be exposed to the side effects of your action. And all we're seeing here is a lead time bias. I actually believe with theranostics and with PSMA PET, we're likely to benefit patients, But we should just be wary about this, wary about finding disease and not necessarily changing the actual disease history. This is a slide from Peter Oss, who's a really impressive oncologist in Belgium. And this is just looking at how we can find oligometastatic disease. Oligometastatic disease hasn't actually been clearly defined. I would say it's probably less than five bone metastases, and that seems to be what seems to be the current definition. And we also don't have the current imaging modality, but I think PSMA PET is the way that we're going with regards to that. But you can see here in the middle panel that you may well have a patient presenting with a couple of metastases after treated local disease. What does that mean? We can intervene, but does that change things for the patient? I believe it does, but we need to demonstrate that. And basically, I believe that what PSMA PET does is it provides a window of opportunity. So it picks up disease at an earlier stage and allows us to intervene and benefit patients. So we know that. Could everyone put their mics on mute, please, just because we hear everything. So we look at the conventional disease stages by conventional imaging. And you can see here, this is just a patient going from localized disease to biochemical recurrence to what we call non-metastatic castrate refractory disease, where they've had androgen deprivation therapy, but they have PSA progression. And there've been some studies in this patient population, and this just shows how PSMA PET could change what we do. This is looking at patients treated in patients who were treated, who were like patients treated in the study, either had non-metastatic castrate refractory prostate cancer on conventional imaging with a PSA doubling time of less than 10 months. And that figure was chosen because that's an inflection point where we see risk of developing of conventional metastases. But you can see here that most of the patients have detectable disease on PSMA PET. Half of them have metastatic disease, others have local disease. And we can see here that if we were using PSMA PET, we would classify these patients as metastatic. And that may well be wrong. And we just need to be careful when we're doing that. So we can identify subpopulations. And I believe we can identify populations that would benefit from local therapy, such as stereotactic radiotherapy, or perhaps consolidation treatments, such as the Theranostics that we're going to hear about. So I would say that when you think about PSMA PET and other novel imaging, think about how we redefine new disease states. So in some ways, for castrate-sensitive prostate cancer, PSMA will pick up new metastatic disease in what we believe was local disease. It may define progression. So we may see patients progress on who novel imaging. We may also see that we may identify this early progression. So after PSA, but before conventional radiographic progression. So we see PSA to PSMA PET progression to conventional progression. So it offers this window of therapy for additional therapies, which I believe have the potential to extend radiographic progression-free survival. But PSA, we know alone, drives change within the community. And I'd say we need to be careful about that. And again, you look, you find, you act is a good motto for, I think, my talk. So we need to be careful when we find things and be thoughtful and reflective with regards to them. So this is just a case, just to give you some thoughts. A patient of ours. So the patient with metastatic hormone-sensitive prostate cancer presents with pretty extreme disease, extensive bone and lymph node disease, and anemic at presentation, presenting PSA of over 200. May 2016, starts androgen deprivation therapy, deemed unfit for docetaxel, which was what we would have used as an additional therapy at that stage, and then the patient declined it. The patient has a good response, and I think that's reasonable to say. PSA nadirs at less than 1. We can see that later that year, later in 2018, the PSA is going up, and on conventional imaging, we see some progression of bone and lymph node disease, and so they're started on abiraterone, which lowers testosterone further. We can see that abiraterone works very well, and that after a year of abiraterone, PSA is undetectable. A few months later, the PSA starts to rise, and rises from 0.5 and then up to 3. Patient has a PSMA PET scan, and the PSMA PET scan shows disease, shows bone metastases. So should we have done the PSMA PET scan? And what should we do now? Should this change therapy? Should we do something? Should we do anything? And again, you look, you find, you act. I don't know the answers here. We can talk about possible treatments, but should we be changing treatments on the basis of this? I would say not at this point in time. So to conclude, metastatic prostate cancer is a lethal illness. We know we need novel therapies in this space. Androgen receptor treatment remains central, but we're in a space now where there's a great need for treatment beyond androgen receptor therapy. Novel imaging, especially PSMA, has great potential, but we need prospective data to demonstrate its role and its ability to change therapy. There is a large unmet medical need post this dual androgen receptor blockade, with lots of patients progressing post abiraterone and enzalutamide, and we need to really think about those. We need to think about alternative treatments. As I said, next generation sequencing, I think, has a role, but I think it's relatively limited. And I believe that PSMA PET is going to be a much more relevant to a greater number of patients, if not the vast majority of patients. PSMA Theranostics, you're going to hear about, it's one of the most exciting areas going forward, and one that I believe will truly change practice. So I thought, as I'm here today with some real giants, that if one can see further, it's often by standing upon the shoulders of giants. And I really feel that's relevant for today. I wanted to finish with a cricket shot, because this is A.B. de Villiers here playing for RCB. And I think when we first saw something like the ramp shot several years ago, we thought, well, that's interesting. I think some people were probably shocked by it. Jeff Boycott, who comes from where I come from, was probably horrified to see this. And I suppose I see PSMA PET in a similar way to the improvisation we're now seeing in T20. It's here, it's relevant, it's beneficial, we believe. Does it have a role across all areas? Well, we're seeing it being introduced. And I think we can see that this innovation that we see in sport is now happening in clinical medicine. So thank you very much for your time. As again, thank Apollo, thank fellow speakers, and particularly thank Ajit for his kindness inviting me today. So I look forward to taking part in the panel and hearing the other speakers. Thank you for your time.
Thank you so much, Dr. Simon, for the illuminative talk, as well as sticking to time. And since we are on the pathway to precision oncology, as Professor Baum suggested, we have to be precise in the timing as well. And thank you so much. And with this, I would like to introduce you to our next speaker, though he requires not much introduction. Professor Richard Baum is the president of the Academy for International Centers of Precision Oncology, and he's also the chairman of the Advanced Theranostics Center for Radiomolecular and Precision Oncology, based out of Germany. And as many of us are aware, he's been a pioneer in the field of theranostics for the past 20 plus years, and has taught us a lot, as well as led the world as well as the way in theranostic application of a lot of molecules, with many of first-in-human studies, as well as guiding of many of the products which are under trial already. So I hope you have a great next 20-25 minutes of learning, as I hope to. Over to Professor Baum. Welcome, sir.
Thank you so much, Ajit, and good morning, good afternoon, and good evening, probably even good night to all the participants around the world. We are now over 150 people listening, and I think it was a great idea to organize such a webinar. And before I start my talk, I would really like to invite especially all young investigators and young doctors to join the ICPO Foundation. The aim of the ICPO is to distribute the knowledge about theranostics all around the world in the different disciplines. So radiomolecular precision oncology is actually part of personalized medicine, which comprises genetics, and this especially today is looking at gene expression profiling and other technologies, as well as intelligence, which contains history taking, which is still important, even in time of all these electronic devices we have, but also multimodality imaging for structural imaging, CT and MR, and for molecular imaging and functional imaging, PET and PET-MR. By this, we can do better therapy selection and monitoring. We can get to earlier diagnosis and better risk assessment, and we can even answer questions of prevention and epidemiology. So Theranostics is a combination of a diagnostic tool that helps to define the right therapeutic tool for a specific disease. In short, one can say we see what we treat and we treat what we see. The term is now more than 20 years old and was first used in conjunction with the Herceptin test, which required an in vivo immunohistochemistry before starting antibody treatment with the HER2 antibody. And I might remember that Suresh Srivastava, our previous WORMS president, created a term for the use of radioisotopes. But nuclear medicine physicians are well known to this term because radioiodine, which was first used in the beginning of the 40s of the last century, is the ideal example for using diagnostic and therapeutic radioisotopes. And we organized in 2011 in Bad Berka the first Theranostics World Congress with more than 400 participants from 56 countries. So personalized medicine is the right treatment for the right patient at the right time and the right dosage. So we are not anymore targeting a disease, but we are targeting the specific tumor of a patient. And the usual way to treat cancer is to observe, to diagnose the disease, and then to take some action and then to re-evaluate the patient after about 3, 4, or even 6 months. But in many cases, the therapy is not working and one have to change the approach to therapy. And by using a test, a molecular imaging test, actually, like PET-CT, we can break the cycle of trial and error medicine and give a predictable response to the patient. That means Theranostics has unique promise for personalized and precise treatment of cancer because we can choose the targeting vehicle and nowadays also different radionuclides with different radioisotopes for the individual patient. And that is what we call radiomolecular precision oncology. So for those who are not so familiar with the technology, I want to explain it very shortly, what means we see what we treat. So on the tumor cell, we have a target which works like a lock. And this can be antigens like CD20, HER2, or many others. There are more than 500 different tumor antigens known today and more than 300 monoclonal antibodies used for that. So this is still a very promising area which needs to be explored in the future. Then we have G protein coupled receptors, for example, somatostatin receptors. We have enzymes or inhibitors of enzymes like the PSMA, and we have transporter molecules. Then we have the ligand, which is the key and fits into the target like a key in a lock. And this can be antibodies, mini-bodies, antibodies, and so on, small molecules, or regulatory peptides, or we are speaking today about the PSMA ligands, or even radiolabeled amino acids. And then the ligand carries a linker and a chelator, which is like a small cage and is holding the radioisotope. we are using for diagnostics like gallium, fluorine, and so on, or for therapy. So we have a reporting unit and we have a cytotoxic unit, mostly for treatment of prostate cancer. Nowadays, lutetium-177 is used, but there are also trials using actinium-225 or combinations of lutetium and actinium. So I was mentioning the Theranostic World Congress, which went from Germany in 2011 to Chandigarh in India in 2013 with Baljinder Singh as president, and then to the United States, to Johns Hopkins, Baltimore, and then to Australia, to Melbourne, where Michael Hofman is coming from and was the main person to organize this congress and the driving force. And the last meeting was actually in Jeju in Korea. And for those who are interested, we are organizing the next congress, hopefully, if COVID-19 allows, next year in Santiago de Chile in South America. So there is a steep increase in therapeutic nuclear medicine procedures over the last years, from 5.9 million in 2014 to more than 10 million this year. And this is a prediction, by the way, from Siemens Healthcare. But I think if we look around the world, the prognosis will be even higher use of radioisotopes for nuclear medicine treatment within the next 5 years. So Nature Biotechnology titled Radioactive Drugs Emerge from the Shadows to Storm the Market after Novartis bought in a $2.1 billion deal Endocyte, which was actually running a trial with lutetium PSMA. And now the real big pharmaceutical industry is interested in this approach, which will also help our field to spread the knowledge of the approach. So radiomolecular precision oncology, what will be the future? I think in future cancers will be classified mainly by genetic profiling and molecular phenotypes, and the organ side like lung cancer, breast cancer, colon cancer, etc., will be a secondary classification. So molecular phenotypes, however, can be quite easily determined by molecular imaging using PET-CT and SPECT-CT, and of course also using molecular pathology, which is still in its infancy if we look at prostate cancer, because nowadays 95% and more of urologists and oncologists are still used to the Gleason score, which is decades old, but still the most valid parameter, and other profiling of tissue has not really achieved a high importance. So treatment will be targeted against the individual tumor of the patient, which is, as I have explained, precision oncology. And nuclear medicine physicians hopefully will become the precision radio oncologist if it comes to therapy. And prostate cancer is really a paradigm for this approach, as molecular radiotherapy is applied based on the molecular phenotype, namely PSMA expression of metastases as defined by PSMA PET-CT before starting the treatment. So this approach is not really new. There has been several attempts and even approval of drugs to treat cancer disease based actually on the molecular target rather than on the tissue of origin. So pembrolizumab, a monoclonal antibody, has been approved, for example, for several cancers based on the target and not on the origin of the cancer. You have heard about all these different methods which exist for treatment of localized cancer and of metastatic castration-resistant or still hormone-sensitive prostate cancer. And over the last years, there were several attempts to prove this treatment as listed here. But unfortunately, after all these efforts, every patient with a metastatic prostate cancer is still dying. Nobody survives. And if you look at the Journal of Clinical Oncology, what are the real advances over the last years? So one must unfortunately say that survival benefit, not overall survival, but survival benefit with chemotherapy is based on the Journal of Clinical Oncology summary 9 to 12 weeks. And for second generation ADT, which you just heard of, like abiraterone and enzalutamide, is about 3 to 5 months. So progression-free survival ranges from 16.5 to 18 months and overall survival from 14 to 32 months in early stages of the metastatic disease. So there is an urgent need for more effective therapies. Now there are new therapies, but they have a number of shortcomings, like some of the therapies are only available in the United States or in Europe. PSA, which is very frequently used for monitoring, is by far not the ideal marker to follow up the disease, especially if we look at more undifferentiated prostate cancers. Then the sequence of therapies is really not clear when to use enzalutamide or abiraterone in addition, and which one first and which one second, or if to use a second and so on, and before or after chemotherapy. So there are many questions open. And finally, we have toxicity of these new treatments, and especially also financial toxicities, because some approaches like CAR T-cell therapy are over $300,000. If we look at enzalutamide and abiraterone and the cost in Germany, one must say that for 12 months treatment, we spent here approximately 60,000 euro or $70,000 for enzalutamide and about $77,000 for abiraterone. So these therapies are not really very cheap. You have heard already about the PSMA, which is a cell surface enzyme that's continually internalized and has GCP2 and folate hydrolase activity. And very, very important if it comes to therapy is that PSMA expression increases in higher grade tumors, metastatic disease, and hormone refractory prostate cancer. PSMA is also present in tumor neovasculature, for example, in some brain tumors and in kidney cancer. And it also is thought to play a role in tumor invasiveness and serves actually as a growth factor for tumors. So what we are targeting is this extracellular part of the enzyme. And Henry Wagner once said, FDG, fluorodeoxyglucose, is a molecule of the century. And I think that PSMA really is a target of this decade. Just to remind you that Martin Pomper, who is now heading the Johns Hopkins Nuclear Medicine department, was the first really to describe with his group this molecule, which fits, like, as I said, a key in a lock into the tumor cell. And I just would like to give you one example on the power of molecular imaging using PET-CT. This patient had a Gleason 9, had a prostatectomy with lymph node clearance 1 month ago, and he had a R1 situation, so microscopic residual tumor at the rim of the primary. and his post-operative PSA level approximately 6 weeks after resection was 0.37. So the treating team wanted to know if there are lesions outside the prostate region before they give external beam radiotherapy to the prostate bed. And I think nearly all urologists or oncologists would handle the case in a similar manner, namely irradiating the prostate bed. But when we performed the PSMA PET, you see that there are many small dark spots outside the pelvic region. If you count, these are more than 13. And actually, there were very small lymph node metastases down to a size of 2 millimeter, which were recognized by PET-CT. But surprisingly, there were also bone metastases, like you can see in the lower image in the iliac crest, despite a relatively low PSA of 0.37. So one very important message is that a low PSA level is not always telling you that there is a low volume of the disease, which is still not recognized by many people dealing with prostate cancer. So what about skeletal metastases? We can not only recognize osteoblastic changes like with skeletal scintigraphy, but we can even diagnose quite small bone marrow metastases where the cancer is really starting to grow out, as shown by this impressive case. And then if we compare the standard United States and the standard Europe, which is F18 Axumin for the States and PSMA here in Europe, we see that the PSMA is much more sensitive and shows many more lesions. So what is our concept in metastatic castration-resistant prostate cancer? We always first perform a PSMA PET-CT. We see what we treat, and then some additional tests are done, especially if there are risk factors in the patient. Then we perform the first therapy using lutetium PSMA. We monitor the patients under the therapy and perform SPECT-CT using the lutetium, which is also a gamma emitter. And very, very good SPECT-CT images can be obtained using lutetium PSMA after therapy, recognizing even small tumor lesions as small as 5 or 8 millimeters in diameter. Then we assess also adverse effects concerning hematological and hepatic function and so on. Then we perform the second cycle of therapy, again monitoring the patient, and before the third cycle we perform PET-CT for restaging, or we can use the lutetium SPECT-CT under therapy for evaluating the effectiveness of the therapy. Usually 2 or 3 cycles are enough to reduce the metastases and to have at least a partial remission of the disease, but one can repeat the treatment many times more. Actually, I have given up to 12 cycles of lutetium PSMA therapy over the years in some patients, depending on the results of restaging. In this case, we even achieved a complete remission of the metastases after 3 cycles of treatment. I just would like to mention that we can also perform dosimetry using, for example, different methods to calculate the doses to the metastases. And we have done that at my previous place in Bad Berka more than 3,000 times in patients receiving radioligand therapy. And you can see that in some cases we achieve really very high doses, more than 400 gray in bone metastases, which then is really killing completely the tumor. There is no resistance and no weapon against really high dose radiation therapy. So these are still data from my previous center in Bad Berka, more than 400 patients treated with more than 1,300 cycles. The mean administered activity at that time was 6.9 gigabecquerel. So nowadays we start with about 9 gigabecquerel and then reduce the dosage for the second and third therapy cycles to about 7.5 gigabecquerel. You see that most of the patients received 3-4 cycles, but also at this time up to 11 cycles. We have published our data quite comprehensively in the Journal of Nuclear Medicine and other journals. And if you look at the patients we have treated, nearly all were under ADT. Most had received also surgical therapy and external beam radiotherapy. About half of the patients chemotherapy as well as other therapies. Now, the most frequent site of metastases were the bone, as can be expected, but many patients also had lymph node metastases or a combination of bone and lymph node metastases. But we also have seen a number of patients with organ involvement like lung and liver, and rare diseases like pleuropericardial, testicular, adrenal, brain metastases, and so on. For those who are interested, there is a complete issue, actually, a special feature of the British Journal of Radiology published end of 2018 on different aspects of PSMA radioligand therapy. I just would like to present you one case with extensive spread of disease after hormonal therapy and radiation therapy. Here is a patient who actually was receiving EBRT in 2005 after radical prostatectomy. Then about 10 years later, his PSA was increasing and he received again external beam radiation therapy to lymph node metastases and was treated with ADT as shown here, trenantone and first bicalutamide, which is a standard treatment. And this is his PET image showing some scattered lymph node metastases in the retroperitoneal area along the great vessels until the level of the kidney. And the patient actually wanted to be treated by PSMA radioligand therapy, but his insurance denied to pay for the treatment. So he first received abiraterone plus external beam radiotherapy to the abdominal lymph node metastases. That was in November 2015. 1 year later, after this treatment, one sees very nice, actually complete remission of the abdominal lymph node metastases, but unfortunately, the disease had spread to the bones, with many new lesions. And then we treated him with 2 cycles of lutetium PRLT. His PSA level, by the way, was also only moderately elevated and not corresponding to the extension of the disease. And after 2 cycles, fortunately, his PSA went down to 0, and there was a complete remission also on molecular imaging. This is the same patient showing the lutetium scans under his first treatment after 20 hours and 70 hours. And on the right, you are seeing the same scans 20 and 68 hours after injection of the second dose for treatment. And what you can see here is that the patient, even after a single cycle of therapy, already had a very good, even complete remission of the disease. Now you have seen how many bones were involved by cancer. However, his hemoglobin, white blood cells and platelet did not change at all over the kind of observation period, as well as his renal function showed no nephrotoxicity at all. And if we look at his PSA level, which is not shown here, but you can look at the numbers, it went down to 0 and remains there. And in our total cohort of 262 patients monitored over a long time, we saw actually a decline of the PSA in 70% and a decrease of more than 50% of the patients was noted in half of the patients. So there were some exceptional patients which I also want to show here, which was also published in Clinical Nuclear Medicine. For example, complete regression of lung metastases, which we have observed in some patients. Here are the gallium PET images, the fusion images, the CT images, and in the left lower corner, the lutetium whole body scans after therapy and SPECT CT images. And he also showed a very good response to the treatment and is still alive after 4 years after the treatment. So I think it is not only the radiation which causes these amazing effects in about 5% of the patients we treat, but that the immune system is also involved. And I suggest it's a term adaptive endoradioimmunotherapy or ARID for this concept. Another very, very important feature is DNA repair. So some patients, and I think our group was the first to have data in more than 100 patients on aberrations and changes, genetic signature changes, which show that, for example, CHEK2 is a very important gene concerning radiosensitivity. Now, chemotherapy is like a bushfire as compared to molecular targeted precision radiotherapy, which really precisely hits the tumor, which is shown by this patient with very widespread disease in the skull, in the spine, in the pelvis, in the ribs, and so on. So if I ask you what toxicity would you expect if you give about 175 millicurie of lutetium to this patient, I think most people would expect some myelotoxicity, especially if you look at the lutetium SPECT CT scans, which show replacement of bone marrow in many of the vertebra of this patient. But astonishingly, there was no toxicity at all. Unfortunately, the graph is not showing up here, but in many patients we have seen an even improvement after treatment. And I think what is described in many papers as myelotoxicity is actually progression of the disease in the bone and in the bone marrow, and not really caused by the lutetium itself. The same is true for the kidney and the liver. If we look on the other hand to the possible adverse effects which occur under treatment with cabazitaxel, which is a follow-up chemotherapeutic after docetaxel, you see that, for example, anemia occurs in nearly all patients, and neutropenia, which is severe, namely grade 3 or 4 in more than 80% of the patients. We also looked at patients with a single kidney and published this series in the Journal of Nuclear Medicine, showing that there was no kidney toxicity, no nephrotoxicity, even in patients with a single kidney, as shown in this case, where the urologist did not timely enough the blockage of the ureter, which led to complete hydronephrosis of the left kidney by lymph node metastasis compressing the ureter. And you see under lutetium treatment, there is a very nice regression of the disease, and the MAX3 scintigraphy, if you compare the curves before and after treatment, you see that there's even an improvement of kidney function after lutetium therapy. So survival benefit for chemotherapy, ADT and alvaradin is actually between 2.4 months and 4.8 months. For radium 223, it was described as 3.6 months. And I'm sure that Michael will present their data, a very, very important paper published in the Lancet on the phase 2, which confirms his single center studies. Overall, our median progression-free survival in the total cohort of patients was 9.5 months, and the median overall survival end of 2019 was 45 months. So in patients without chemotherapy, we could even achieve a mean overall survival of more than 50 months as compared to those receiving chemotherapy before, where it was 20 months less. And the worst were the group of patients after cabazitaxel with a mean overall survival of around 18 months. So I feel that early initiation of PSMA radioligand therapy is effective in mCRPC and may offer a significant survival benefit. And as I said, Michael will surely comment on this and give their experience using randomized clinical trials. So the question is, should we be treating earlier? And this doctor, a 62-year-old internist, suffered from partially neuroendocrine differentiated hormone refractory prostate cancer and presented in February 2016 with severe pain due to metastases, mainly in the sacral bone compressing the nerve roots. He had to give up his practice, but he refused chemotherapy because his wife had been dying from breast cancer some months ago, and he had seen all the adverse effects. So he had a locally recurrent disease. He had pelvic lymph node and disseminated bone metastases. And you see the whole body scans under the first, second, and third radioligand therapy. And fortunately for him, in October 2016, he had a complete remission of the disease. His PSA level went down from 356 to 0.0. He could restart his practice as a doctor and playing regularly tennis. Now, many people ask how long lasting is this response? And fortunately, in this patient, we have a follow-up over a very long time. So this is July 2017, 17 months, still complete remission. The same for 30 months, July 2018 and August 2019. And actually the patient will come in about 2 weeks for another control, and his PSA level is still 0.0, 54 months after start of the PSMA radioligand therapy. So we can probably start to dream not only of complete remission of the disease in some patients, but even of curing some patients with metastatic prostate cancer, which is actually not possible with any other method nowadays. So others like Mike Satek from South Africa also have treated chemotherapy naive patients with advanced cancer, and this is published in the European Journal, showing quite impressive results in this patient, for example, with a bulky lymph node metastases. After 2 treatments with actinium, there is complete remission, and this is not Photoshop, this is really happening in some patients. Another patient with poorly differentiated prostate cancer and extensive pelvic and retroperitoneal lymph node metastases, as well as a secondary tumor, refused treatment with chemotherapy, and we treated him de novo with radioligand therapy. And you see the big lymph node metastases in the iliac region nearly disappeared, as well as the other metastases disappeared. And then we have given him, in addition, proton beam therapy for his primary tumor, and he is still in complete remission after this combined treatment, which I call COMBIR, combination of internal and external radiotherapy. Charles Huggins was already mentioned, and we should not forget about the benefits of ADT. He described also in his Nobel Prize lecture, the results are often spectacular, and this was definitely the first revolution in the treatment of prostate cancer, which is still true today. This is a young patient with liver metastases of prostate cancer, and after treatment with bicalutamide and the GnRH antagonist, he has a complete remission of the disease. So ADT is very valuable and useful in many patients, but we are unfortunately dealing mostly with patients resistant to ADT. So the next step would be to use a radioisotope with a higher power of energy. For example, the linear energy transfer of alpha emitters like bismuth is about 100 times greater than for beta emitters like lutetium, though they are causing a double strand break of the DNR, and that means death of the tumor cell. And the second revolution really was treating incurable patients like this one with widespread disease and even progression under lutetium treatment. And then with the treatment of an alpha emitter in Heidelberg at the German Cancer Research Center, there was still a complete response after actinium in this patient. We went further and combined lutetium and actinium, like in this patient where there was also progressive disease under lutetium alone. And after a small dose of only 5 megabecquerel actinium, this patient also showed a complete remission of the disease. I would like to finish with the take-home messages, which are that PSMA radioligand therapy is effective in end-stage disease. We see tumor regression, and we can even, in those cases with far advanced disease, achieve complete remission as last line in some patients, and probably even cure in a few patients. Significant improvement of clinical symptoms. This is something I have not really pointed out, but which is from a practical point of view enormously important, because many patients have relief of severe bone pain even a few hours after the PSMA radioligand therapy. And I think we and others have shown that we can prolong progression-free survival and probably even could provide a substantial survival benefit from patients failing conventional therapies. The treatment is excellently tolerated. We have seen no or really minimal hematological toxicity, especially in chemotherapy naive patients. We have seen no nephrotoxicity. We just 2 weeks ago have treated by accident, so to say, a patient which had no kidney function and had to undergo dialysis after our treatment. And after getting nephrostomia bilaterally, his creatinine return completely to normal. So one can even treat patients without a kidney function. And we have seen very low numbers of persistent salivary gland toxicity with lutetium, which is the other way around with actinium, which is very toxic to the salivary gland. But by combination as tandem therapy, we can again reduce the toxicity. So patient selection and response to therapy assessment after PRLT follows the Theranostics concept using molecular imaging, not only gallium PSMA, but also fluorine 18 PSMA is nowadays available. And I think one really should start a trial using a combination of lutetium and actinium and monitor the disease with molecular imaging. And as mentioned several times, Michael will discuss prospective clinical trials, which are now coming to an end and hopefully will confirm what we found in our single center studies. So my last slide is from Henry Ford, who died in 1947. And he said, anyone who stops learning is old, whether at 20 or 80. Anyone who keeps learning stays young. And the greatest thing in life is to keep your mind young. And I think this is very much true even during the corona pandemic. And I would like to thank my friend Ajit Shinto for organizing this webinar and giving us opportunity to learn and to keep our mind young. Thank you.
Thank you, Professor Baum, for your excellent lecture. As always, he's always been known as an excellent orator and very, very powerful images with some outstanding responses and also impressive improvements in quality of life, tolerability to treatment, and the entire sequence from diagnosis to beta-based therapy to the current alpha-based therapy, and his outstanding experience. Thank you so much. And there has been a lot of messages on the chat window for Professor Baum to answer if he'd be so kind, or I could do so. And I've been trying to hold the fort on that side. We have almost 250 participants who have logged in from almost 20-25 different countries. And for those who have missed out the initial part, my name is Dr. Ajit Shinto. I'm a nuclear medicine physician in India, and we are almost 50% through this webinar. The first lecture was an introduction to PSMA by Dr. Simon, and who's a clinical oncologist. And right now we have just finished listening to Professor Baum, who's a nuclear medicine physician from Germany, who has expounded on his experience in PSMA diagnosis as well as therapy. And next, we have with us one of the not rising stars, probably only a risen star in his own right, Professor Michael Hoffman, who is the director of the Prostate Cancer Theranostic and Imaging Center of Excellence at the Peter MacCallum Center. And this is a very unique concept that they've come out with, which is actually ProsTiC, which is the Prostate Cancer Theranostic Center. And I'm sure because of the immense utility and benefit that they've seen for PSMA, both diagnostically and therapeutically in their patient set, is the reason why Australia is leading quite a bit with regards to the number of clinical trials that are taking place in this particular space. And we have Lancet as well as any JM publications, and he's also handling multiple clinical trials like the therapy, the Upfront PSMA, the Vision trial, the Pro PSMA, and I'm sure he is going to elaborate on a few of them, and we shall definitely benefit from his experience, as well as also a learning point for us nuclear medicine physicians to combinedly work with urologists as well as oncologists and develop trials and to generate evidence for this wonderful theranostic molecule. Over to you, Professor Michael Hoffman.
Thank you, Ajit, and pleasure to speak to everyone from all corners of the world. And it's always a pleasure to speak after Richard Baum, who's given an excellent presentation, and also Simon Chowdhary from London. But Richard's Baum work really inspired me very early on to really pursue a career in theranostics. So a special thanks to Richard. Now, just a few disclosures. So this is where my interest in PSMA Theranostics arose. This publication back in 2015 using one of the first generation small molecules, MIP-1095. It was radio-labeled to iodine-124 for PET-CT imaging and then I-131 for therapy. And in this very small series of only 25 patients, they showed a PSA response over 50% and 61%. And these men had failed standard therapies. So this was really exciting data back in 2014. And then in 2015 at the third World Theranostics World Congress in Baltimore, Professor Baum presented his PSA results in the first 37 patients he had treated with this compound called PSMA INT, labeled to lutetium-177, also showing a very impressive response rate. This was followed shortly after by the first case report using this molecule, lutetium PSMA 617, showing a complete response in this man after only 2 cycles of therapy. And really back in 2014, we had access to some of this early data, particularly Richard Baum's data that he's presented. And we put together a prospective. You might just want to mute yourself, so we put together this prospective clinical trial protocol. We had a background in treating neuroendocrine tumors with lutetium-177, much like Richard Baum, back in 2015. And our neuroendocrine program was growing, and a lot of the infrastructure and equipment needed to do PSMA is very similar. We label to gallium for the PET imaging and lutetium for therapy. So we were able to transition across very quickly. And we did it as part of a prospective clinical trial. This was perhaps a little bit different than what our German colleagues were doing with compassionate access therapy. So we had a very strict inclusion criteria. Most of these men had progressed after both docetaxel and abiraterone or enzalutamide, and 50% of this cohort had progressed after cabazitaxel chemotherapy. This was initially a 50-patient cohort, a 30-patient cohort, published in Lancet Oncology back in 2018, and more recently, the updated results of the 50-patient cohort published in Journal of Nuclear Medicine earlier this year. And we saw a PSA response over 50% in 64% of men, which is quite a remarkable response rate. This was using PSMA 617. That was an asset when this trial was started, was licensed from the University of Heidelberg in Germany to ABX in Germany, and subsequently to Endocyte, and more recently purchased by Novartis. These were the 8 best responders in the series of 50 men showing PSMA PETs before and after treatment, and really some exceptional responses. And many of these men, as I said, had failed 3 or 4 lines of therapy. And despite that, some of these men achieved undetectable PSA. And this slide shows us how beautiful PSMA PET is for imaging and evaluating treatment responses. But it is worth noting that out of the 50 men treated on this trial that started 5 years ago, actually we recruited the first patient almost exactly 5 years ago, there's only 3 men surviving from this cohort today, which is still remarkable for those 3 men. But this is a subset of the better responses and not necessarily representative of the average response. So here is one of these exceptional responders. And some of these patients just have exquisitely PSMA avid disease, and we get very high doses of radiation. So this was a 69-year-old man. He had progressed after docetaxel, enzalutamide, abiraterone, and cabazitaxel. And he had this rapidly progressive retroperitoneal node, which was actually causing severe back pain. It was highly PSMA avid, also highly FDG avid. And you can see the distribution of his disease predominantly in lymph nodes, but also within bone. And our dosimetry after only the first cycle of treatment demonstrated 175 gray delivered to this lymph node. His PSA was rising prior to treatment very rapidly, with a doubling time of 1.8 months. And after treatment, his PSA declined at a similar kinetic rate, but in the reverse direction. And his PSA actually became undetectable after 3 cycles of chemotherapy, after 3 cycles of lutetium. And it remained so for around 18 months, at which time PSA started progressing. And as Richard alluded to, we can give further cycles of treatment. And we treated him again at about 22 months later. And you can see his duration of response became shorter, but we've continued to give him further lutetium treatments upon every progression. And we now have 4.5 years follow-up on this man. And I'm pleased to say that he remains alive and well and asymptomatic. His PSA is starting to rise again, and we're planning to give him another cycle of therapy. That will be actually his 10th cycle of treatment. But this is not a typical response to lutetium PSMA. This is perhaps the 10 to 15% of really exquisite responders, but they, still merit a lot of reporting, because this man had progressed after chemotherapy, enzalutamide, abiraterone, and cabazitaxel. To have this sort of result 4.5 years later is really remarkable. So this was our results from retreatments. Actually, out of that 50 patient cohort, we gave further lutetium PSMA at a time of progression to 30% of those men. And we saw a PSA response over 50% in 73% of these men. But it is worth noting that these responses were less durable than we saw initially. And here you can see the change in PSA from baseline with really some long-term follow-up. And you can see that there's only a few people in the tail end that have, exceptionally durable responses. So I think what we see from this graph is that, after 2 to 3 years, most patients are progressing to a point where the lutetium is no longer helpful. And so we do have a problem with durability, particularly after 2, 3, 4 lines of therapy. Importantly, this therapy is extremely well tolerated, as Richard alluded to. We don't cause much in the way of side effects, and patients who have pain at baseline often have a rapid reduction in response in pain. These are the data from the quality of life questionnaires that our patients completed, and really we saw a marked improvement in pain after cycle 1, and this persisted across the cycles until 3 months follow-up. How do our results compare to others? Well, our response rates are a little bit better. Our PSA over 50% response, 64% compared to 45% in a multi-center retrospective series from Germany in 145 patients, and only 32% in this 100-patient retrospective series from Munich. So our series was prospective and had a higher response rate than the retrospective data. Now, this is perhaps a little bit unusual. Often it's the other way around. Why is this so? We think it's because of our patient selection. So this is a patient with extensive bone metastases, SUV max of 70. This is a measure of intensity of uptake on the PSMA PET scan, and this is a very high number. So we may rush to treat this patient with lutetium PSMA. But we have also been performing an FDG PET in all our patients. And what we see is that there are extensive hepatic metastases that are FDG positive, PSMA negative, and also some bone disease that has FDG uptake but no PSMA uptake. So this is disease that we cannot target with the lutetium PSMA therapy, but it's also the disease that's FDG positive and has the most rapid proliferative rate, the highest kinetics. So if we can't target the most aggressive disease, then we're unlikely to do good with our treatments. So we direct these patients away from lutetium therapy and think about, well, what else can we do? Is there a role for cabazitaxel or carboplatin etoposide chemotherapy or something else? So we do see this tumor heterogeneity, which is very interesting. In this patient that I just showed you, actually, he has bilateral supraclavicular nodes, but on one side, they're PSMA positive, FDG negative, and on the other side, they are PSMA negative, FDG positive. And when you think about gene expression profiling or next generation sequencing, you typically biopsy a single site of disease and you subject it to this type of analysis. And what we see on PET imaging not only in prostate cancer, but also pretty much any other malignancy, is this tumor heterogeneity. But it's very nicely visualized when using dual tracers, both PSMA and FDG. And we think there's a lot to learn from perhaps biopsying sites of disease with different molecular phenotypes and learning, well, what are the different biologic characteristics? So we can have these sort of 4 sets of molecular imaging phenotypes. On the left, we've got patients that really have a very low PSMA uptake at all sites, but very high FDG uptake, clearly unsuitable for lutetium PSMA therapy. Then we have patients with the discordant disease, some sites that are PSMA positive, but other sites that are FDG positive, PSMA negative. We consider those patients unsuitable as well, although some of them may well benefit symptomatically from lutetium therapy. And then we have patients that are suitable. They can be FDG positive, as we see in this patient here, but they're also PSMA positive at all sites, so we can target all their disease. And these patients do very well. And then we have patients that are PSMA positive and completely FDG negative. So what happened to the patients we didn't treat? When we screened these for our 50-patient cohort trial, and we followed up the patients we didn't treat, and they had a median overall survival of only 2.5 months. That's a unbelievably poor survival. This compared to a median overall survival of 13.3 months in the patients that we went on to treat. And if we looked at the patients who had a PSA response over 50%, they had an overall survival of 18 months. One of the nice things we can do, which Richard also alluded to, is that we can quantify radiation doses. In our centre at Peter MacCallum in Melbourne, we use a very advanced technique using 3-time point, 3-dimensional quantitative SPECT-CT images, and we merge these together, and we get our computer to estimate the radiation dose to every pixel or voxel in the scan, and we can produce these whole body images of radiation dose distribution. So on this rotating image, anything in red, such as these adrenal metastases, have received over 50 gray, and anything in the gray scale has received 15 gray or less. And then what we did is we looked at the mean dose to tumor, and if we achieved a mean dose to all of tumor of less than 10 gray, we saw 10 non-responders and only 1 responder. So using PSA at 12 weeks as our response measure. So this tells us that this is not a magical treatment. It simply delivers very high doses of radiation to tumor. If we're able to get high doses, we have good responses. But if we achieve less than 10 gray as an average dose, then we're not likely to see many good responders. We've also looked at our molecular imaging phenotypes in that cohort and prognostic factors, and we see that our metabolic tumor volume on FDG PET is actually probably the most prognostic factor. If you have a high metabolic tumor volume over around 200 mils on FDG PET, survival was much worse. PSMA intensity was also prognostic, so men with higher PSMA uptake did much better. This is the group up here, as we would expect, delivering more radiation to tumor. So after this 50-patient single center, single arm trial, we really acknowledge that our oncology colleagues want randomized control data with a control arm to really evaluate how much better this is to existing therapies. So together with the ANZUP Cancer Trials Group and some funding from the Prostate Cancer Foundation of Australia and Movember, and some industry support from Endocyte, and we put together the therapy trial, a multi-center randomized trial comparing lutetium PSMA 617 to carbazitaxel, 200-patient trial, 11 sites around Australia. And we have completed recruitment of this trial. We randomized patients around 6 months ahead of schedule, highlighting the interest in lutetium PSMA. And we recently presented the results at the ASCO annual meeting. This was the initial results, and I'll share with you them today as well. So here's the slide I already showed you, but what I can tell you is in the therapy trial, around 28% of men were ineligible on screening on the basis of a suboptimal phenotype on PSMA and FDG PET. Our primary endpoint was PSA response, defined by a reduction over 50%. And this occurred in 66% of men randomized to lutetium PSMA, compared to only 37% in men randomized to cabazitaxel chemotherapy. So that's a pretty big difference, a 29% absolute improvement in the lutetium arm. This was highly statistically significant. At the time of this first analysis, we did not really have robust progression-free or overall survival data, but I can let you know that we have actually just pushed the trigger on that analysis. That was an event-driven analysis, and we have just run that analysis, and we hope to present the results maybe at the ASCO GU meeting early next year. We do have adverse events from this initial readout, and what we could see is that in terms of any adverse event, we saw more grade 3 to 4 severe side effects with cabazitaxel, 54% compared to only 35% with lutetium PSMA. This was not necessarily attributable to drug. This was just any adverse event that we observed, which was often due to disease progression, but being a randomized trial, it's very clean, telling us that lutetium appears to have significantly less side effects than cabazitaxel. We saw a lot of diarrhea, neuropathy, altered taste, neutropenia with cabazitaxel. The main side effects with lutetium PSMA were dry mouth, dry eyes, and this was usually pretty minor, grade 1 to 2. Thrombocytopenia was probably the main side effect with lutetium PSMA. You can see that this occurred in 11% of men, grade 3 to 4 with lutetium PSMA, compared to none with cabazitaxel, and grade 1 to 2 in 17%. So I think what this study tells us is that in men with progressive disease, all these men progressed after docetaxel actually, and 91% had progressed after abiraterone and enzalutamide. Lutetium PSMA was more active than cabazitaxel, using this PSA response rate with relatively fewer grade 3 to 4 adverse events. This early data did show a PSA progression-free survival favoring lutetium PSMA, but it was a little bit early. As I've alluded to, we'll have the radiologic PSA progression-free survival and the mature PSA progression-free survival, and also quality of life data and the early overall survival in our next analysis. Now, this was a trial which involved really a lot of people from around Australia. So I just want to thank them all. This was a great collaboration of nuclear medicine specialists with medical oncologists at each of these 11 sites around Australia. You know, one of the great things about this trial is that it got the nuclear medicine doctors working really closely with medical oncology colleagues, and this network that's been established continues to function today with a range of new trials that I'll tell you a little bit about now. But before I do that, I'll just let you know about the VISION trial. This is not a trial that I've been involved with, but an industry trial set up by Endocyte, now Novartis, a registration level trial run at 9 countries. I think they randomized 815 men with progressive castration-resistant disease after taxane and after novel anti-androgen. So similar population to the therapy study, to lutetium PSMA or best supportive, best standard of care. And the primary endpoint is overall survival. We await the results of this trial eagerly. We thought they might be presented at ESMO a few weeks ago, but alas, they were not. They'll be presented sometime next year, maybe early next year, maybe in the middle of next year. I think the anticipation is that this will be a positive study, but we really need to wait to see this data. If it is positive, it will lead to FDA approval and I think global widespread availability of this technology. As I alluded to in that image of the year, that spectacular image showing the responses, 50 men in that trial, but you know, almost all the men have passed away from prostate cancer. So we do need to do better. And this was a review article I wrote with a colleague of mine, Dr. Aravind Ravi Kumar from our center. And we looked at how can we improve lutetium PSMA therapy even further. And perhaps I'll touch on some of these methods now. But one of them is combination therapies. And we're running this trial called the PRINCE trial, where we are combining lutetium 617 together with pembrolizumab. And this is a single-arm trial. We have actually almost completed recruitment of this trial, so we hope to have the results next year, maybe at ESMO or ASCO. And this is based on the principle that if we sensitize cells with radiation damage, that the immune system, by activating the immune system, we can have synergy between immunotherapy and theranostic therapy. We really await to see this data eagerly to see whether this is the case. Richard Baum alluded to the concept that the immune system is really vitally important in control of malignancies. Another technique we're trying to do to improve outcomes is combining lutetium PSMA with olaparib. This is a PARP inhibitor. Now, PARP inhibitors are used in prostate cancer in men who have mutations in BRCA1 or BRCA2 or some other genetic mutations. But here we're not using olaparib in patients with DNA repair mutations alone, but we're using it in any comers. And here we're using the olaparib as a radiosensitizer. So when we damage tumor cells with radiation, they actually repair themselves, much like when you get sunburnt and you get a bad sunburn, your skin heals itself. Tumors actually do the same after radiation damage. So olaparib, being an inhibitor of DNA repair damage, actually enhances the effects of radiation damage quite profoundly. So we've done this trial quite carefully with a dose escalation design where we started the olaparib at 50 milligrams twice a day. That's a very small dose of olaparib because we were worried about toxicities with this combination. And over the course of this trial, up to about 37 men, we're escalating to a full dose of 300 milligrams BD. We're currently up to the 200 milligram BD dose, and I can tell you anecdotally that it appears to be, very well tolerated. And again, we hope to finish recruitment of this trial by the end of this year or the beginning of next year, and then be able to report the results. Richard alluded to the fact that lutetium PSMA may be better if it's given earlier rather than later. And we believe the same, but we think this should be done only as part of prospective clinical trials, because really abiraterone, enzalutamide, docetaxel are proven life-prolonging therapies in prostate cancer. And we don't know that lutetium is better than these proven therapies. So I think we ought to give these proven therapies first before we go for lutetium, unless we're studying it as part of a clinical trial where we can, produce high quality data, whether we're as good or better. So this is the trial called the Upfront PSMA trial. It's running at that same therapy network of sites with the addition of a few other sites. And we're taking men with newly diagnosed prostate cancer and metastatic disease. They have to have a high volume of metastases defined by a PSMA PET and high intensity of uptake. And then we're randomizing them to upfront lutetium as a very first line of therapy, followed by standard of care docetaxel or a docetaxel alone. And the primary endpoint of this study is undetectable PSA at 12 months. And this study is underway. I think we've got about 5 of our 10 sites or 5 of our 12 sites open to date, and we are actively recruiting. So a really exciting study running at this network of sites. We also have another exciting study called the Lutectomy Study. This is a play on the word lutetium and prostatectomy. Now, this is run by our surgical colleague, Professor Declan Murphy, a urologist. And this is a patient at the top from our phase 2 study who had actually widely metastatic disease. This is actually that man who had the spectacular response post docetaxel, abiraterone, enzalutamide, and carbazitaxel. But he had residual disease in his prostate bed as well. And we saw that we delivered 78 gray after the first cycle of treatment, and we were able to show this in our nice dosimetry image. And in fact, after completing lutetium therapy, there was no disease left in his prostate gland. And this images and similar patients got us thinking this may be an effective treatment for patients, as an adjunct, neoadjuvant to surgery or radiation, external beam radiation, or perhaps instead of. So in this study, the Lutectomy Study, we're taking men with high risk localized prostate cancer with or without pelvic nodes, but without metastatic disease. They have to have high PSMA expression, which we define as an SUV max over 20 on a gallium PSMA PET. The first 10 men are getting 1 cycle, the second 10 men 2 cycles of lutetium. They're then proceeding to standard of care prostatectomy and pelvic lymph node dissection 6 to 8 weeks later. And the primary endpoint is dosimetry. How much radiation can we get to this primary tumor? And then we're looking at pathologic response, imaging response, and safety. This study is just being run at in our centre at Peter Mac, and it's recruiting really well. I think we've done four patients to date, and we've identified the next 3 or 4 patients. So COVID-19 has slowed our recruitment down a little bit, but we're well on track to complete this study. And I think this is a really exciting study. Here's just a sort of infographic highlighting the study protocol. This study is thanks to a large grant from Movember, together with support from Endosight. And we're also running another randomized trial together with our colleague from Sydney, Louise Emmett, called the ENZA-P study. This is a randomized study, 180 patients running at all those 10 sites that we established for therapy around Australia. And we're randomizing men to either enzalutamide in combination with lutetium PSMA or enzalutamide alone. And these has a lot of PET imaging for early restaging at day 15, day 92. We're trying to look at in the enzalutamide arm, do we get upregulation of PSMA after starting enzalutamide? And there's a variable number of lutetium cycles depending on the response on the PET scans. So this study is also recruiting around Australia. So in the next few years, we're going to have really a lot of interesting data to present to you. I just wanted to highlight some other papers that our group has published recently. Those that are embarking on lutetium PSMA therapy, we published this manuscript entitled Practical Nuances and Intricacies. And we just go through some of the practical aspects of lutetium PSMA therapy, such as how we interpret this mixture of FDG and PSMA scans. We also talk about salivary protection and just some practical things that we do when we administer this therapy. We see some patients with very extensive bony metastases, and we're concerned about hematotoxicity in these patients potentially. But we recently looked at retrospectively, together with our German and American colleagues, at a multi-center retrospective series of lutetium PSMA in men with PSMA super scans. And these were the 43 men. You can see just extensive bone marrow involvement. And despite that, the treatment was pretty well tolerated, grade 3 thrombocytopenia in 17%. So that's just a touch higher than the 11% seen in the therapy study, and grade 4 thrombocytopenia in 8%. So this was really a well-tolerated treatment. And the PSA responses were quite high, similar to other series. So we conclude that it is safe to give lutetium in patients with very extensive marrow metastases. One of the things we do in our center, as Ajit alluded to, is we work really closely with our uro-oncology colleagues, both our urologists, medical oncologists, and radiation oncologists. We have a tumor board meeting every week where we sit together and discuss these cases, and this is a really good thing. So I think anyone doing this therapy should be doing it in really a close collaborative network, and we are, reviewing pathology together with radiology, together with PET imaging, and very nicely in this meeting. We've recently established the Prostate Theranostics Imaging Centre of Excellence that we've called PROSTIC at Peter Mac at our centre. This is thanks to a very large philanthropic donation from the US-based Prostate Cancer Foundation. They've given us US $5 million, which our institution has matched. And we want to expand that portfolio of clinical trials from around 5 trials to around 10 trials. And we want to provide some education and leadership and do some discovery research as well. So if you want to keep up to date with what our group is doing, you can follow us on Twitter. That's our Twitter tag, pros_tick. We regularly actually hold some global exchange webinars together with our colleagues at the Prostate Cancer Foundation. And last week only, we held this one on next generation PSMA ligands, and we had a really dynamic lineup of speakers. We spoke about alpha therapy, terbium, Auger emitters, albumin binding therapies. I can tell you we actually had 950 registrants for this, and remarkably, 600 people online all at the same time. We've had a remarkable number of people at this meeting too. I could see when I joined at the beginning, I think there were 150, and we rose up to 250 during Richard Baum's speech. So an excellent attendance. We do record all of our webinars, and you can play them back. We put them on YouTube, so you can subscribe through this link and to our YouTube channel, and you'll find a recording of that webinar. So please subscribe to our YouTube channel to stay up to date. Just a shout out to all my collaborators, both at Peter Mac and around Australia, and our funding partners and industry partners that enable all this work to happen. So thank you very much. It's been a pleasure to participate in this webinar, and I will hand back to Ajit.
Thank you so much, Professor Michael. That was extremely inspiring, if I can say the least, as a nuclear medicine physician. And, to look at the way that we have progressed. And I did my training for a bit of a time, PET-CT in Peter Mac. And from then, you were already doing neuroendocrine tumor and gallium scans before PRRT at that time. And I could see the inspiration and the enthusiasm on you. And you have taken this to a whole new level. And I feel Australia is really leading the way with regards to scientific data generation. And it's something that we in India should definitely learn and collaborate very strongly with the oncology and the urology community. And precisely for that reason, I'd like to thank you, Michael. Before I go on to the next one, we have a clinical medical oncologist who's going to lead our panel. And I request Professor Baum, Michael, and Simon to also join the panel. I would like to introduce you to Dr. Raja. Dr. Raja, T. Raja is our senior medical oncologist and director of oncology in the Apollo Group in Chennai. And along with him, we have 5 other esteemed members who are going to join us. We have Dr. N. Raghavan, who is our urologist. And we have Dr. Nitesh Jain, who's again a consultant endoscopic and laparoscopic robotic urologist. We have Dr. Vedang Murthy from Tata Memorial Hospital, who's a radiation oncologist with a special interest in uro-oncology. Dr. Rejiv, who's a senior consultant medical oncologist, again with a special interest in uro-oncology. And Dr. Ramanan, who's also a senior medical oncologist. So we have 3 oncologists, 2 of them medical oncology, 1 is a radiation oncologist, 2 urologists, and 2 nuclear medicine physicians who are going to be on this panel. And of course, we have the very charismatic and charming Professor Raja to take over, being the moderator of the is Dr.
Ajit, you're able to hear us?
I can hear you.
So Ajit, can I proceed? You were briefly interrupted, Ajit.
I think Ajit is frozen. Just proceed.
Yes. Thank you, Professor. Thank you. And I'm Dr. T. Raja, medical oncologist at the Apollo Cancer Center. And I thank Ajit for inviting me to lead this panel. But after 3 excellent lectures from Professor Chaudhary and Professor Baum and Professor Hoffman, and again 5 of my very, very eminent colleagues who are all very accomplished. I mean, I must say that I feel a little bit intimidated as a novice to talk to this elite group of panelists. I'll try to do my job to the best of my ability. Thank you for this opportunity. And we heard the length and breadth of what PSMA Theranostics is all about from our 3 eminent speakers. They talked a bit about its applications in diagnostics and its application in therapeutics. So we'll try to pay attention to both aspects of the PSMA Theranostics, diagnostics a little bit, and then we'll move into therapeutics. So I'll begin with my Indian panelists. This is the first basic question I have. When would they consider PSMA diagnostic scan in their prostate cancer patients? And how and why they think PSMA scans are superior to the conventional scans for the prostate cancer. I'll begin with my medical oncologist, Dr. Rejiv. If you are there, can you please take up this question, Dr. Rejiv?
Yes, so the first part of the question is when would you order a PSMA scan? So I would definitely order when it is in patient is diagnosed as CRPC, so castrate-resistant prostate cancer. As a baseline staging, I would consider as a PSMA scan because the positive predictive value and sensitivity and specificity for picking up metastatic sites is high. Where the other point would be when would it be done is when there is a high risk localized prostate cancer again, the chance of picking up additional metastatic site is higher. And one thing which we will be worried about as medical oncologists is when we are suspecting neuroendocrine or small cell transformation or neuroendocrine type of transformation in prostate cancer, that's one place we may not ask for a PSMA PET and we will be doing an FDG PET because there you will have low PSA and a high disease burden. Then FDG PET will be a good option for a neuroendocrine variant.
Thank you, Dr. Raj. Touch upon those challenges with PSMA scans very soon. How PSMA scans are superior to the conventional scans for the prostate cancer. I'll turn to my other colleague and Professor Ramanan, who is also a very senior medical oncologist. Professor Ramanan, if you are there, why would you want to do it, and do you think it is superior to the conventional available in your day-to-day clinical practice? Professor Ramanan.
Thank you, Raja. Definitely, this traditionally we were doing bone scans and sometimes, whole body MRI. But I do feel PSMA scan has an edge, particularly once we are given local treatment, either radiotherapy or surgery. And if there is a creeping PSA, we really need to know whether this disease is locally there or whether there is systemic disease. And here, definitely PSMA scan is going to be very, very helpful. Because we are doing the scans regularly nowadays, only elevated PSA after local treatment, we don't get that situation that frequently. We are able to find out disease somewhere. Even a very small amount of disease gets picked up by using PSMA scan. So it's this place I would really find that this scan is very useful.
Thank you, Dr. Ramanan. I have also, put up the paper from Dr. Aber, which talks about the rate of detection of metastasis, 1.2% with conventional CT to 32.7% additional diagnosis. So that's a very significant number, and also additional regions being picked up from 6% to 24%. So that's a very significant. This is one of our own patients whom we have done the gallium PSMA scan, and this is at the diagnosis, and later on we went on to treat them with conventional treatment modalities, and we did this is still in the diagnostic domain, a very good response in the PSMA scan. This is another patient who has a scan at the diagnosis and after treatment went on to show a very good response. I'm talking about treatment with the conventional methods. I'm not talking about the lutetium therapy yet, but this is our diagnostic application. But I would like to ask my surgical colleague, I would turn to Professor Raghavan. This is a meta-analysis, systemic review and meta-analysis presented this year by Professor Wu and Kafour. In this, they would like to talk about what is the, for local staging of prostate cancer. Would you be interested in doing your PSMA PET scan? Particularly, you are very, very interested in your robotic surgeries, Dr. Raghavan. Would you apply this pre-surgical staging in the local staging of prostate cancer?
Thank you, sir. Thank you for this question. Good evening, all. I have moved a long way from in the late 2012 and 13 when I did MRI and bone scan in the pre-diagnostic setting to today. I am doing a single test called PSMA PET MRI that covers both the systemic staging as well as gives the staging for MRI. In India, we have the opportunity to overlap the MRI and PSMA, and therefore we get excellent reports which cover both the areas. MRI is still an excellent tool for local assessment in terms of the prostatic assessment, especially helps in targeting your biopsies as well. But adding the PSMA with the MRI really adds to the benefit of it. So the standard of the standard test which I use today is a PSMA PET MRI for diagnosis.
Thank you, Dr. Raghavan. As you alluded, PET MRI, greater sensitivity, and your PSMA gives you the specificity. This is the coupled forest plots for the sensitivity and specificity, particularly for seminal vesicle invasion. And this is a meta-analysis of about 12 studies, 615 patients, and this is the coupled forest plots for sensitivity, specificity for seminal vesicle invasion and extraprostatic invasion. So, would you think that this would tell you how to choose your patient? Can I say that, Dr. Raghavan?
Sir, absolutely, sir. I completely agree. I think PSMA PET MRI is now the standard of care in terms of diagnostic pathway. At least and we also have the advantage in India that it's widely available. There is no dearth for this test to be done. It's widely available as well. It gives both the anatomical and functional images, and therefore really it is the standard of care now, sir.
Thank you, Dr. Raghavan. I'll turn to my other surgical colleague, Dr. Nitesh. When will you be calling for a PSMA PET scan? Particularly, I want to ask you about something else. When you have a suspicion of, clinical suspicion of a prostate cancer, do you think in that setting, calling for a PSMA PET CT will be helpful in the initial detection of prostate cancer patient when there is a clinical or biochemical suspicion? I have put up another, systematic review and meta-analysis published again this year, which talks about its role in the, positive and negative prediction of initial diagnosis. How comfortable will you be accepting such an option, Dr. Nitesh?
Right now, actually, only once the prostate cancer is diagnosed, we prefer to do a PSMA PET scan with MRI. As an initial modality, without a histopathological diagnosis, we don't do PSMA PET scan. But there are few situations like a patient with a rising PSA where we are done MP MRI, we have done couple of biopsy, all of them are negative. Probably in those particular scenario, that particular scenario, we can opt for doing a PSMA PET scan with MRI without having a histological proof.
Thank you. I've just put up this paper more as a, kind of a provocative. This test can have a high accuracy, and again with the coupled forest plots, pooled sensitivity and specificity for both positive and negative predictive value is talked about. I know I would like to turn to my international colleagues. Particularly, I want to ask Professor Michael Hofman. Sir, would you be using this modality when you at an initial diagnosis of prostate cancer? What will be your experience and what will be your advice to us? Professor Hofman, if you're there.
Oh, thank you. Thank you for the question. So actually, we have answered this question fairly definitively in a big randomized control trial that was published in The Lancet in March this year. And this was actually the establishment of that network that was used for the therapy trial. I didn't present the pro-PSMA trial, but in the pro-PSMA trial, we took men with newly diagnosed prostate cancer who had Gleason score 3, 4, or 5. So that's a 4 + 3 = 7 or 8 or 9. And they were randomized to either a PSMA PET scan or a CT and bone scan. And then we followed patients up for 6 months. and defined the endpoint. And what we saw was a overall accuracy, I think of 90, I have to pull out the paper, I don't have it in front of me, but there was a 29% absolute improvement in accuracy of PSMA PET CT compared to the combined findings of CT and bone scan. That was for detecting lymph nodes or distant metastases. So it was around sort of 65% to 92% accuracy. So a really big difference. And not only did we see an improvement in accuracy, but we saw a big change in management, double the high management impact with PSMA PET compared to bone scan CT. We saw less equivocal findings. We saw less radiation dose actually with the singles test rather than both scans. And this was a 200 patient study, actually a 300 patient study run at 11 sites around Australia. And I think it's not common to get nuclear medicine papers published in, the Lancet publication. And so that really has established PSMA PET CT as a new gold standard. And we've actually also done a health economics analysis of the cost. Is it more cost effective to do a PSMA PET rather than a CT and a bone scan? So when you do the PSMA PET, you no longer need to do conventional imaging. And we actually present the results tomorrow at the European Association of Nuclear Medicine meeting, which is a virtual meeting. It was going to be in Vienna. And I can tell you, we do show, health economists show that PSMA PET, it's not only more accurate and changes management, but it's also reduces costs, both short-term and long-term costs. So we think PSMA PET's the new standard of care.
Thank you, Professor Hoffman. But I just want to draw your attention to a couple of papers which talks about the predictive value and the correlation of PSA cutoff value and the PSMA PET CT. I have put up this paper for you. Again, Gleason score as correlate with, you may not necessarily be 100% accurate. There could be some issues, particularly with lymph node sizes and so on and so forth. So would you address those questions when we have diagnostic challenges with PSMA PET scans?
Yeah, no test is perfect. We will not see lymph nodes be below 3 millimeters in size with the PSMA PET. And we know when our surgeons do lymph node dissections, they sometimes find 1-2 millimeter deposits, but it still changes management. So I think if you have a PET scan with positive lymph nodes or distant metastases, it enables our surgeons to sometimes move away from surgery. It enables our radiation oncology colleagues to change their radiotherapy treatment plan. So it's still a very accurate test. No test is perfect, but significantly better than MRI, CT, or bone scan.
Absolutely, your point taken. I would turn to Professor Baum, Richard Baum, who's a pioneer, who probably is one of the leader in establishing this therapy across the world. But I would like to draw Professor Baum's comment on how specific is PSMA expression. I find that we can find expression in other malignancies like thyroid carcinoma, and he did talk about some of these during his lecture, and particularly, he touched upon lung cancer, and this is a picture of the celiac ganglia also being positive. So, Professor Baum, your comment on PSMA expression being slightly off the prostate. Can you please help us on that, Professor Richard Baum?
Yeah, thank you for the question. Actually, the term PSMA is not correct, right? It is not a prostate-specific agent, but it is targeting, as I showed in my presentation and was mentioned, the GCP, right, is an enzyme which is present mainly in prostate cancer and overexpressed in prostate cancer, but it is also present in many other tumors. You have shown examples like thyroid cancer, very frequently in renal cell cancer, in brain tumors, and so on. And there it is mainly not in the tumor cells or tumor cell membrane, but it is in the neovasculature. And for imaging, it might be useful in some instances, but unfortunately not for theranostics, because when we are labeling the PSMA with lutetium and perform a biokinetic study, we see that in many of these other tumors, aside from prostate cancer, there is initial uptake for a few hours and then the molecule falls off the target cells, or let's say falls off the endovasculature, and you do not achieve sufficient dose. Though there has been no convincing data up to now that PSMA is useful for theranostics outside the prostate cancer field. And I think Michael made many good points in his answer to you. The most important is that there is a very close correlation, and you shortly also demonstrated the slide, between PSMA and Gleason's score. That means as more undifferentiated the tumor cells are, as higher the PSMA expression. And all the old studies you have mentioned from 2015 and so on, forget about this. These people were not looking at a selected patient population like Michael Hofman and his team did publish in the Lancet, where you really look at high risk patients. Nobody needs PSMA PET in low risk patient. It's useless, right? Gleason 6, you do not need PSMA PET. You need PSMA PET in Gleason 10, 9, 8, and probably 7B. Okay, that's where it is useful and where it also has a prognostic meaning, and where the numbers are totally different from the stupid papers you have demonstrated just looking at prostate cancer. Prostate cancer is not an entity which is homogeneous, but it is very heterogeneous. And we know, that PSMA PET also gives you prognostic information, about the uptake and the course of the disease. So please forget about PSA, okay? Look at PSMA if it comes to more advanced undifferentiated prostate cancer. This is a major message I really want to give to all urologists and oncologists, because you are still PSA bound, right? You always look at PSA, all the studies showing when PSMA PET is becoming positive. I can show you patients with a PSA level of 0.05 and widespread disseminated disease. It's not PSA, it's a PSMA, and the differentiation grade, which is important.
Thank you, Professor. Those are very, very, pertinent and very strong advice. We will take it. And thank you for your, very, very wise comments. We'll move on to the therapeutic application of this particular, technology. And, these studies were presented, very elegantly by Professor Baum and also by Professor Hoffman. And, we are just clinicians, and we are only aware of few of those studies, but this is an important paper, German multicenter, study of nearly 145 men, which was presented in 2017, and the Peter McCallum data, as Professor Hoffman pointed out, this was first presented in ESMO 2017, and then now he showed the updated versions of these data. And he also showed that the PFS and the OS data as time has matured. But I would like to come back to Professor Baum. As the ligands have evolved and the chelating agents have evolved, lutetium-177, is that the standard of care right now? And you talked about the alpha therapy and all that. So now where are we heading currently? What is the standard, Professor Baum? And can you talk about these ligands and the radionuclide agents for us?
Yeah, thank you very much again for this question. I think the standard of care today is really lutetium-177 PSMA. And there are small differences between the different ligands shown here, like PSMA INT and 617. These refer mainly to the elimination kinetics from the kidney. If you look at the uptake and half-life in tumor, and we have done more than 100 comparative patients which received INT and then received 617, and the dose you achieve in the tumor is nearly the same. So 617 is a little bit more rapidly excreted from the kidney, but as I have shown, there is no damage to the kidney at all from lutetium PSMA treatment. Okay, so you can take any PSMA which has a long half-life in tumor, and lutetium, I think, definitely is a standard. Concerning actinium, I would reserve it for patients with progression under lutetium treatment and having not a mismatch, as again shown very elegantly by Michael Hofman. So this information from the FDG PET, which refers again to, I would call it, anaplastic prostate cancer. Though these patients have no PSMA expression, you know, they are just very aggressively growing cells, not expressing any more PSMA, but having a very high proliferation rate, as shown up by the FDG PET. So I think we have to look in this patient cohort resistant to lutetium PSMA, not only with PSMA, but also with FDG PET-CT, and then makes the right decision to go on with what we have shown, tandem treatment, because actinium, as I also mentioned in my talk, is quite toxic to the salivary glands. So about 30 to 40% or even more of the patients treated in Heidelberg and Munich in Germany had to stop the treatment because of very dry mouth, dry eye syndrome, and so on. And by the tandem treatment, we cannot avoid this completely, but we can reduce the severeness and the frequency of high-grade xerostomia in these patients. But this is still research. There is none, really prospective trial on that. I mean, we have done about 100 patients over the years now, but the data are not yet really analyzed concerning overall survival and progression-free survival.
Thank you, Professor Baum, for your really insightful overview. I'll turn to one of my Indian colleagues, Professor Vedang Murthy from Tata Memorial Hospital. At this point in time, you have heard all the going. Clinically, what are your for therapy, Dr. Vedang? You have to unmute yourself, Dr. Vedang.
Yeah, I did that. Thank you so much. So can you just repeat the question, please, Dr. Raja? I missed that. There was some disturbance.
Thank you. At this point, what are you heard the lectures from 3 very eminent speakers, but then at this point, clinically, until yesterday or by Monday or the next week, what would be your indications for referral for therapy with lutetium PSMA therapy?
Yeah, so I don't think based on the lectures I will change anything. I think we have a reasonably robust practice of use of lutetium PSMA therapy in our hospital. But I am encouraged to see that the responses can be so dramatic. I mean, we only heard it, we read about it, but I mean, it was nice to see all these wonderful responses. Although, as the speaker said, this may not be always the typical case, and I mean, you always get varied types of responses. Having said that, I think this is only going to increase in the coming days, in the coming years, and hats off to Michael and his colleagues in Australia. I mean, you really changed the way the world is seeing these therapies. So, I mean, that is what I would just like to say. Thank you.
Thank you, Professor Vedang Murthy. Fortunately, we have had some experience at the Apollo hospitals with the therapeutic aspects. I would just like to know, this is one of our patients who was treated with the lutetium-177 therapy, and you can see that, you can see the response pre and post, and this is our one of our patients. This is another patient, once again. You can see the scans and you can see the post-therapy SPECT CT, and you can see the pre and post-therapy response in most of the areas that was previously clinically noted. And but on the other hand, there was a mixed response. There was a progression in one spot. I mean, I'm just I know you had 3 excellent lectures, but I'm just presenting our experience at this point. But we would like to really, look at the options with renewed interest after hearing these lectures.
Can Dr. Raja, can I just add a couple of queries probably to this audience if you have your permission?
Yeah, please, quickly. Yes.
So the big challenges I see as a clinician of using these, I mean, cost is clearly one issue. I mean, it's not as exorbitant as some of the newer drugs, but still cost is an issue, and that is coming down. The second one is we have some disturbance. The second issue is about scheduling. I mean, this has been my experience. I'm not sure if this is even true or there's work around this. When you want a patient to have a PSMA therapy, I mean, it takes a while to get the whole thing set up. The availability of the drug and availability of the radioisotope, etc. So how does one deal with this as a clinician?
Dr. Vedang, I mean, I on behalf of as the center gets more and more into this, I think these logistics issues can be clear. I can just, I'm a clinician, but I can, on behalf of our radionuclear colleagues, I can say that the lutetium therapy alone, we have already come to 100 patients we have crossed. So we have very good experience on that, and we have sorted out all these questions that you are asking. We will talk later on offline about certain issues with your permission. Thank you. I'll try to move on, but I would like to pose this question to Professor Simon Chaudhary, if he is there. Professor Chaudhary, you talked about various options as the prostate cancer evolves, but do you think we heard the lecture from Professor Hoffman and how the therapy itself is now being moved upfront, the vision data and the therapy, and he presented some very, very interesting, options like, upfront PSMA options. Do you think the PSMA therapy has really moved forward, Professor Chaudhary, if you are there? Otherwise, I'll pose this question to Professor Hoffman. Do you think that clinically now this will take a center stage in the early phases of the disease? And can you also comment on some of the emerging data on a dose escalation and a fractionated application of these therapies, Professor Hoffman?
Oh, thank you. Look, my own practice is that I think we have enough evidence now with not only therapy but also all the retrospective multi-center studies from Germany to know that this is a very good treatment option for men who have sort of progressed after standard therapies. There's no question about that. So I think this is an appropriate use of lutetium today. But to bring it back earlier to upfront PSMA, so first line, before chemotherapy, before enzalutamide, is not standard of care, and I don't think it should be used in that setting today. This should only be done as part of a clinical trial, because it's possible that our clinical trial will show that there is no added benefit or even worse, or toxicity. We do not know. And really early on, like in lutectomy, this is really highly experimental. I just don't think this should be clinical practice. But I urge you, if you can, to set up some clinical trials to study this. But I think its current use is really after enzalutamide and abiraterone, probably after docetaxel, unless you're not suitable for docetaxel. There are, elderly men older than the age of 75, or men who are frail or comorbidities not suitable for chemotherapy. Clearly, lutetium PSMA is an option for those men. But in our practice, if you're young and fit, we are still using docetaxel and enzalutamide abiraterone first before we do lutetium PSMA. But there's certainly hope that we move it back. And maybe if we move it earlier, as Richard Baum suggests, this is the sweet spot, and we will get better responses and more durable responses. But I don't think we have the data to really know this to date. Have we lost our moderator?
Yeah, obviously.
Raja's line got cut from the looks of it.
Yeah. I just want to say, Michael, I fully agree with your statement, especially concerning the use in older men or in patients unfit. And this unfit is not only bone marrow function, on this unfit is also cardiac disease. This unfit is pulmonary diseases, restrictions, and so on. Renal problems after diabetes, many reasons. And what you have presented at your very end, this multidisciplinary team approach, which we have established already many years ago for neuroendocrine tumors. I think this is really the solution to the problem, and is very important to look at a patient not only from one angle, but really from different sides, and then select the best therapy. I think in my experience, many patients after 80 years or older than 80 years really tolerate PSMA like water infusion, right? They do not report any adverse effects. They go out of the hospital and ask me, did you give me water or did you treat me? And you see quite good responses there, which prolong life, which improve quality, which takes away pain. And there I would very much hesitate to give them docetaxel or even cabazitaxel, which is really a toxic drug. I have shown the data, 80% neutropenia and so on, which brings patients to the intensive care unit when they suffer from infections and so on. So one really have to perform a prospective clinical trial on that, and you are the master of the clinical trials, and I really think we have to go on and set up a trial in early use. Your upfront trial is looking at something like this, but we should probably specifically look at very old patients also. Thank you.
Yeah, no, I completely agree with all those sentiments.
Dr. Raja has signed out for some reason. So in the meanwhile, there were a few questions that were put up on the chat box before. So till Dr. Raja signs in back again, I'd just like to ask our medical oncology colleagues, with the present experience that you have after referring patients for PSMA therapy, are you happy with the responses that you see? I mean, are you with the improvement in quality of life, with the PSA response, with the imaging response? Dr. Ramanan?
Shinto, as of now, I have not made a single referral. So, but after seeing today's presentation, I'm really definitely going to make a referral. But otherwise, and like all the professors have said very nicely, that it's down there at third line. So after I finish my chemotherapy, enza, abiraterone, various sequences, definitely I would be considering now.
I think that is a very definite valid point. At least in the previous place that I was working in, our oncologists actually were, after seeing the responses and their patients coming back to them, not complaining of anything at all after quite a bit of toxic stuff, they were really happy to refer patients a bit earlier on itself for PSMA therapy. I mean, that was my take on the matter. So unless we utilize it in the first patient and see the response, it might be a bit of a challenge because it's relatively new, I agree. But though we've been using it for the past 5 to 6 years in India. Anyway, I think Dr. Raja, are you back on?
Yeah, I'm back. Are you able to hear
Yes.
me, Dr. Ajit?
Yeah, please.
My apologies. I left, but I was just trying to ask Professor Hoffman and Professor Baum about the newer emerging areas of interest of combining, but he really touched upon all these things with the other targeted agents and the ongoing interest in combining this with PARP inhibitors and the checkpoint immunotherapy. They already pointed out that these are all still in the domain of clinical trials, but area to watch out. But I want to come back to Professor Hoffman on, he touched upon this data on the long-term follow-up of their patients. And he presented these impressive pictures. I just want to ask him about his comments on the overall survival and the progression-free survival, and how is this going to impact the overall survival of CRPC patients? That's what I want to learn from him, if it's possible, Professor Hoffman.
Yeah. So I think if we look at this slide that you have, which is
your own paper, yes.
If you look at our 50 patient trial post abiraterone, post docetaxel, 50% after cabazitaxel, overall survival of 13 months. Without a control arm, it's very difficult to know, well, how long did we prolong survival for? We know that the men that we did not treat in that trial, that we screened that had the FTG discordant, only lived 2.5 months, but they're not comparable groups. So I think the medical oncology community really waits for randomized data in order to make a statement that we improve overall survival. Having said that, Richard and I have no doubt that for some men, we have improved survival because we've shown you cases of exceptional responses in men who are really progressing in dire states that maybe had weeks or sometimes only maybe 1 or 2 months to live, but 4 or 5 years later, they are still alive. But these are not the most common cases that we see, but we certainly do see them. I think when we look at the average, we really await probably the results of the VISION trial. And I expect the results will, perhaps show an improvement in overall survival on average in the range of several months, like 3 months, 4 months, maybe 5 months, something in this order in a randomized trial design. That's my expectation, which may be, a touch disappointing compared to what people were wanting. This is not a therapy that extends your median survival by, I think, 2 years or 3 years, although in some patients it will, but on average, it's in the order of many months. But I think what's important is not just the duration of life, but the quality of life. And this is probably where lutetium PSMA is a big winner because it's such a well-tolerated treatment. Not just well-tolerated, men are feeling better, decreased pain, decreased fatigue. My impression is with chemotherapy, often the toxicities of treatment mean that you might be extending life, but there's a detriment to quality of life sometimes because of toxicities. So I think when we compare, let's say, lutetium to cabazitaxel and Unfortunately, you'll have to wait for the results of our quality of life and overall survival and progression-free survival to be presented early next year, I hope. But I think what we might see is really, a lot less toxicity than carbazitaxel as a major thing. So my analogy there may be similar to early. If you think of currently a patient presenting with newly diagnosed metastatic disease, high volume, you can either have, if you don't have lutetium, you can have docetaxel or abiraterone enzalutamide. And many men prefer to go for enzalutamide abiraterone rather than docetaxel because the hormone treatment is much better tolerated, less side effects. We have data showing that, in fact, the survival between docetaxel or enzalutamide in that setting is similar, but the enzalutamide is much better tolerated. So I think lutetium, let's say, versus carbazitaxel may be a similar equation. Carbazitaxel, actually a very active drug, but with significant side effects. So if you have a choice between lutetium and carbazitaxel in the future, I think you will be choosing lutetium because of disadvantage of quality of life and perhaps a little bit extension of survival as well.
Thank you, Professor. And my apologies that I presented your own paper to you and asked excellent papers, what you have done, your Lancet and the 2020 update that I saw. Thank you for really educating us. I'll turn the last question to Professor Baum. This is kind of gazing into the crystal ball. This is the current and future application of theranostics. What is your comment on the neoadjuvant application, upfront application? Can you give us a futuristic overview, Professor Baum? And with that, I will close. Thank you, Professor.
Professor Baum, before you answer, kindly also touch upon the other theranostic applications in other cancers as well. Just a brief.
Okay. So I
It's
have
going to be a very long answer.
Okay. In theranostics, as I have shown, has very wide applications, and most established currently are, of course, the neuroendocrine tumors, which are not so fragment like prostate cancer, but already approved after 20 years of single center studies all around the world, including our center in 2017 in the European Union, and later on in 2018 the FDA approved lutetium dotatate for treatment of neuroendocrine tumors. So this is the first approval of a new therapeutic after so many years, and I think there are very promising other traces or ligands which we can use. For example, just recently the FAP, which is fibroblast activation protein, which looks terrifically good for imaging, at least for more than 40 different kinds of cancers, from colon to lung to breast, ovary, pancreatic adenocarcinoma, and so on. And just 1 year ago, nearly to the day, we started to treat patients with lutetium FAP, showing that there is some effect, but we need still to work on that. So I think the future of theranostics is really very bright. Concerning PSMA, I think Michael made an excellent summary of what is currently the state of the art and what are future trials he's already running or which can be performed. I just would like to add one small other thought, but which I think is very, very important. We still need to better stratify our patients. So we know that there is a certain number, I would say between 3 and 5% of patients which have miraculous responses, complete remissions in patients. I call them the Christmas tree. They light up on the PSMA PET in every bone and lymph nodes and so on. And they show spectacular responses to our treatment, whereas other patients, do not respond at all and progress under our treatment. So what the hell is a reason for that? And I think Michael has some ideas. I think we were the first to make a statement that, the genetic disposition and certain genes involved in DNA repair are probably the major figures, the major player to answer this question. And that is where I think we need to go to within the next 12 months to really find out what genes, make a patient the ideal patient for such an, exclusive, or how did you say, Michael? You used a very nice word.
Exceptional.
Exceptional response. And why are other patients not responding as well? So precision medicine, precision oncology means that we really precisely define the best indication for each individual patient, which is a lot of work, right? It is not, excuse me, I do not want to harm anyone, but it's not chemotherapy, everyone 6 cycles, and then do restaging. We really have to look very, very detailed into the patient's history, in his age, in his genetic signatures, in risk factors and so on. So it is much more than just, an injection of lutetium and that's it. That is my last word, and thank you all for listening.
Thank you, professors, all 3 of you excellent lectures. I thank my panelists for allowing me to pose these questions. And with that, I hand it back to wonderful opportunity. Thanks, Ajit. I hand it back to you for your final comments, Dr. Ajit.
It was an excellent interaction between everyone, and really thank you so much for the panelists for being so patient and being with us throughout this 2.5 hours, and for the excellent talks that all of you have contributed, Michael, Professor Richard, and Simon, for taking so much of time out. I really don't have much else to say, but the comments that I can see on the chat box are very, very heartening. And I really thank you all for spending this valuable time with us, and cheers to Theranostics. Let's look at the way forward. God bless and a good night.
Thanks so much.
Just the last word. I go now to our ward and inject 2 patients with lutetium PSMA. Have a nice evening, a nice day, and a good night.
Likewise. And tomorrow we treat 8 patients with lutetium PSMA. So a busy day ahead.
Okay. Bye-bye.
Thank you.
Thank you so much. Thank you so much. Thank you, Dr. Rejiv, Dr. Ramanan, Dr. Raghavan, Dr. Raja, and all of you who have been very patiently waiting throughout this 2.5 hours. Almost, we still have more than 100 people on. So thank you so much. Wish you have a safe and good night. Stay safe in these difficult times. Thank you.
Thank you.